pain is influenced by a large variety of other components that other authors have or presenters have brought up already. For us, important is age is important, parental expectations, previous pain experiences, but also previous experiences the parents have had. And I will come back to that in the talk on chronic pain. Secondary gain, sometimes it's very difficult for us to tell. A child might have some school phobia, but also has pain. If the pain keeps him home from school, that might become something that they would like to achieve, so they might report their pain more commonly. Cultural background, we talked about it at lunch. Different cultures, different ethnic groups express pain differently. It doesn't mean they experience or would rate their pain differently, but towards a medical provider, they might express their pain differently. There are cultures who will express grief more openly, wailing women at a funeral, whereas others, that would just not be something you would have in your society. Pretty stiff upper lip or so forth. That would be what they would have. And you will have, as a provider, you have to deal with people with different backgrounds, and then also have to consider your own background. All right. Modalities of pain management. There's a whole list. I will only look at a couple of these. I will spend a little bit more time on the non-pharmacological for the chronic pain. And then opioid analgesics. I'll talk a little bit about IV PCA in children, and I have a little bit on regional anesthesia in children for post-operative pain management. Most of the time what we look at is this kind of, oh, this moved too, this is funny. Sort of a pyramid where cognitive behavioral treatment, non-opioid, from fewer side effects, risk to riskier procedures, essentially. So, patient-controlled analgesia for adults, very common. For children, until into the 1990s, that was not a common therapy in children. And even nowadays, and I have data that we can look at, it's not universally used for all children, and particularly not for children of all ages. Indications, post-operative, severe medical pain, and so forth. These are the most common medications: morphine, hydromorphone, fentanyl. You can also do patient-controlled analgesia with epidurals. So this is what we use at Hopkins right now, and morphine, hydromorphone, fentanyl. There has never been shown any real difference. It's an advantage why you would use one of these drugs. In the early 1990s, in children, there was a crossover study between morphine and hydromorphone, and the patients with hydromorphone had a little bit better mood, and that was the only difference. There's no difference has been shown in adverse effects or so forth. We use continuous rates, but that's not universally the case. So many children's hospitals in the United States will just use bolus dosing. Continuous rates have been shown to improve sleep in an inpatient population, but is also associated with an overall increased opioid use by the end of your stay. If you have a surgery and then a three-day stay, a patient who has received a continuous infusion will always have received more opioids. We feel that the children have better pain control, at least in our setting, with this setup of continuous and bolus dose. The bolus dose, when a child has 2 boluses an hour, that to me means we really have to do something. They have to stay on the button to get ahead of their pain. So it's a little bit more physician run, whereas in an adult it's really completely patient run and initiated. Okay. The controversy that exists in pediatrics is what do we do with this little patient here? We can assess their pain, we're pretty good at that, but can we use PCA? And who should push the button? Can the nurse push the button? Can the parent push the button? And that is not equally practiced throughout the United States. If you think of a patient has, say, tonsillectomy, and that patient goes home, that little child goes home, and the parent will then decide, the child has pain, when to give, say, the oxycodone or the codeine. And we don't question this then, that the parent should decide when to give. They get instructions every 4 to 6 hours. But when they give it, that's really the patient's or the parent's decision in a small child. So why should it be any different with the PCA? They can push the button. They see the child is in pain. The drugs, it's opioids, not any different. It's just one is PO, the other one is IV. Not any different there. So we have at least stayed with the philosophy that nursing administered or parent administered PCAs can be used. And we have data, I don't know whether that's in here, one of my colleagues, Connie Manito, actually did a study. There are some risks. The risks with nursing or parental controlled PCA can be higher. That's not from our study, but another study that has been published since then. If you use exactly the same, your standard drug regimen. So if you use a drug regimen that is appropriate for an otherwise healthy child who comes in for a back surgery, you cannot use the same regimen in a child, say, who has cerebral palsy, who has some increased sensitivity to opioids, a child who has obstructive sleep apnea, or so forth. So you have to make adjustments to it. So you cannot just go ahead and use the same. So you need to use your clinical experience as well. There's one thing that I didn't, while I was talking, I thought about. Continuous infusions in adults are not recommended, and there's a warning against this, and that's why there's the controversy in pediatrics. It has been associated with respiratory arrests in an older population, so in older adults, geriatric population. All right. Yeah, these are the PCA by proxy or authorized PCA. So you have to monitor patients, and you have to work with the family members, and have to have some protocol